to say thanks ahead of time for taking the time and talking with us. And I mean, so I guess that's all I have for now. So whenever you want to start, just go for it.
Absolutely. Well, welcome everyone. It's a real honor to get to talk to you guys tonight. I'm totally blown away by the call that was organized at the end of last academic year.
Wait, how?
Who were there?
So it looks like 2/3 or 3/4 of you guys are new.
Yep.
Wow. Well, kudos to all of you, and kudos to Colin for bringing it all together. I was thinking we could do a few things tonight. My understanding from Peter was that it would be kind of fun and interesting for us to find a little bit of maybe a little bit of discussion about the global health space more generally, with updates from the field of what we're doing in Liberia, and sort of a recurring theme of gratitude to all of you for engaging with us in that work. Does that sound about right to you guys?
Yes.
Yeah, sounds good.
Okay. So I thought I'd begin by talking a bit about global health and primary care. I had sent around an article to Colin earlier today. Sorry for the short notice. I don't know if any of you guys had a chance to take a peek at that.
Yeah, I think maybe most of us did.
Okay. Awesome. So let me just say a couple things before we turn to the article. But why primary care? Why make that distinction, or try and blur that distinction? And I think there's a couple reasons. First of all, this is the 21st century, the century we're living in now, looks a lot different than 50 years ago, or even 20 years ago from a health perspective. You all know this to be true. So if you think about, just think about the urban neighborhoods that you're familiar with. Think about the huge amounts of disparities that you feel around you between people who don't have access to basic services or reliable continuity services here in our country, versus those who seem like they have as much access as they want. There's several tiers of care right here at home, and that level of disparity and fragmentation is probably magnified, if anything, the further we go down the chain of wealth and influence. So that if you look at countries like Liberia, for example, you have a very small number of elite who had access to the country's natural resources and have sent their children abroad to study in England and the US, and themselves travel around the world. They're really global citizens. And then you have a vast slice of the population that is getting by on less than $1 a day, and often has access, doesn't have the money to afford services. They can't even necessarily access services even if they had the money, since the health was so badly unraveled and really destroyed by the war. It's not that much, those exist in many countries as well. So if you think about Mexico, for example, a country I've come to know a bit better through some colleagues, Mexico City on the one hand looks, upper ends looks a lot like really wealthy cities anywhere around the world, but right next door to some of these beautiful villas that are up on the hillsides are slums. And that degree of compression of wealth between rich and poor, whether it's completely in your face or it occurs at some distance, I think that's one way of understanding the kind of tension that that we see all around the world today that's magnified compared to how it used to be 20 or 30 years ago. That tension plays itself out in increased levels of mental health disorders, substance abuse. It's been shown to actually correlate directly with how well people do in general in terms of their overall life expectancy and how to deal with a whole range of chronic disease. That inequality itself seems to have a lot to do with health over and above simply the absolute level of their income. Another key global trend that we see over the last 10, 20 years has been what's been called the rise of chronic diseases. And you guys may be familiar with this argument, but these are the kind of diseases that we are used to seeing people die from: heart disease and stroke, cancers, diseases caused by smoking and inactive lifestyles and high-fat diets. These have been called, they're thought of as diseases of affluence, but in fact, today, they actually, the burden of that disease has shifted to lower and middle income countries, so that what is called the epidemiologic transition has occurred, where as populations shift into cities and they have more disposable income, it makes some of these same choices that that we do in our own society, and then suffer from the same diseases. But interestingly, in the poorest countries, even as that's occurring in cities, in the rural areas, it's not occurring, and folks in rural areas are suffering from similar infectious diseases and problems with childbirth and malnutrition, just like they did 20, 30 years ago. And it leads to this, what's been called the double burden of disease, which actually requires a concerted and slightly tailored response to those two different epidemics. This is just a little bit of a very brief introduction into what has made healthcare and the health response in this century so complex. It is really a sort of textured, multi-layered response that requires recognition of some of the systemic failures that have a lot to do with the way that a life-saving treatment actually needs to be delivered all the way to the people who need it, and all the steps along the chain that can go wrong. If the system is failing, we need a systemic solution or a systemic response. And that's where primary healthcare comes in. Primary healthcare is this idea, as we'll take a look at together in the article, that everybody has the right to an essential set of dignified healthcare and services that is evidence-based, it is community-specific, community-driven, it's multi-sectoral, it considers the implications of trade and employment or security and so forth on health, and it's not just focused on the health facilities, and it becomes a foundation, if it's delivered successfully, for security, for development, for shared prosperity across societies. And that's a vision that's not new, and yet it's extremely relevant still today. And so, sorry for rambling a bit, thanks for your patience. What I thought what we could do, is to actually look at this document that had been written in 1978, and reflect on the key conclusions from that document and the way in which it's incredibly valid still today. So if okay with you, actually, I'd like to invite you guys to join me in reading these conclusions together, and then we'll spend a few minutes reflecting on for us. Do you guys have that article in front of you by any chance?
I think we're just gonna pull it up right next to you, so everyone can see it.
Okay. So I don't know if we could just start at one end of the room. What I'd like you all to do, if you have a piece of paper or something, you can just jot notes down. As you read these 10 key conclusions, just note the things that really stick out to you, the things that call your attention, particularly the things that seem very timely, even in 2010, though the article was written in 1978. And after you read through all 10, I'd love to hear some of your thoughts, and we can have a conversation about that. So why don't we start to my left, I guess your right, and go to the key conclusions, which is on page 4, I think, of the article, and just go ahead and read it out loud, and we'll give it a moment, and then we'll go to the next person until we've got all 10. Sound good?
Yeah.
All right.
Number 1, health is a state of complete physical, mental, and social well-being. It is a fundamental human right. Attaining the highest possible level of health is a worldwide social goal that requires the action of many sectors.
2, the existing gross inequality in people's health status is unacceptable and is of common concern to all countries and people.
3, economic and social development is essential to attaining health for all, and health is essential to sustain development and world peace.
4, people have the right and duty to participate in planning and implementing healthcare.
5, a main goal of government and the international community should be the attainment of all peoples by the year 2000 of a level of health that will permit them to lead a socially and economically productive life. Primary health care is the key to attaining this goal.
6, primary health care is based on practical, scientifically sound, and socially acceptable methods, and technology made universally accessible through people's full participation and at a cost that the community and country can afford. It is the central function of the health system and its first its first level of contact, bringing health care as close as possible to where people live in.
7, primary health care evolves from a country's own conditions and addresses the main health problems in the community. It should lead to progressive improvement of health care for all while giving priority to those most in need.
8, governments should formulate policies and plans of action to make primary health care part of a comprehensive national health system in coordination with other sectors. This requires political will to mobilize domestic and external resources.
9, the attainment of health in any one country directly concerns and benefits every other country. All countries should cooperate in the development and operation of primary health care throughout the world.
10, an acceptable level of health for all people by 2000 can be attained through better use of the world's resources, much of which is spent on military conflict.
Awesome. Thank you. So, so what did you hear? Anybody? Go ahead.
The first thing that stuck out to me was the first couple, when it talks about health being a social problem and something that has to be addressed over many fields, not just in terms of the actual practice of medicine, but something that involves community and sort of what we as GlobeMed do is address that, because we're not professionals, we're not, we don't have degrees in medicine, but we make an impact through what we do on our campus and what we individually do to kind of, bring awareness to problems of healthcare, and, the work that we do to try and support Tiyatien Health kind of addresses that problem.
Absolutely. Health is a state of complete physical, mental, and social well-being. It's a fundamental human right. This is actually the first time in history that the world came together, the WHO came together, and member countries from all around the world ratified this statement that health is a fundamental human right, and it's more than the absence of disease. It's really this interaction of the broader context of our well-being, so that health becomes a vehicle for the kinds of things that we want to do in our lives, the kind of lives we want to lead. It was radical then for this to be for this statement to come forward. Alma Ata is located in Kazakhstan in the then Soviet Union, so it had a whole political overlay as well, as the article discusses. But I think you're absolutely right that even today it rings as a kind of rallying call, because so much of health care that we see is so narrow in its focus, and clearly the closer we get to really vulnerable populations that don't have a range of services, the more it's incumbent upon those of us delivering those services to recognize that there are no artificial divides between the conditions in which people live and work and die and their health, and to just deliver medicines without attending to the deep poverty or the mental illness or the political disempowerment would be keeping our eyes closed to the scope of the problem. So absolutely right. I think your reflection on that broader definition is so important. What else did you guys hear?
Something? Sorry. Go on. Go ahead.
Something that hit me is the priority to those most in need, which is kind of like Paul Farmer's preferential option for the poor and like his liberation theology king, which is especially radical for that time and kind of cool.
This idea that you should be served according to your need, not according to your ability to pay. Absolutely. That this is, if you think about the conversation that we didn't have in our country around healthcare reform, we never really asked the question if it was the right thing to do. We didn't have that debate. That's a really notable omission. When Mexico, just to the south of us, 10, 15 years ago, was reforming their healthcare system, the first question they grappled with was, do you really believe that one person's life is worth more than another? And that was discussed in Congress. That was the Ministry of Health pinning key senators down and asking them, do you really believe that one person's life is worth 100 times more than another's? And they would say, of course not. But then he'd say, well, if you would look at your policies, that's the way that the money flows, with a 100-fold disparity between the richest and the poorest sections of the society. We need to align our policies with our values. But I don't think I heard that conversation in our country when we were having the healthcare reform debate. It's pretty exciting to see that in 1978, that was acknowledged as a global focus to begin with the question of what's right, and then allow the policy to follow. You're right. Still seems radical today, unfortunately, but it can be helpful to realize that this is where global health began. This is in many ways, the founding document that has been revisited here in 2003 and again in 2008 with a document that I didn't send you all, but you're welcome to pull and read if you want, which is called Primary Health Care. Now more than ever, it's the 2008 World Health Report of the World Health Organization, and it basically reiterates these same principles of Alma Ata, but reshapes them into a slightly more interlocking, interdependent mode. But the conclusions are essentially the same. The sort of rededication to health as a fundamental human right is a broader goal to link our shared prosperity and development is fully there. Thanks for that comment. What else did you guys hear?
I just thought it was interesting that they keep referencing the year 2000 and how that's going to be the year that everyone's going to have, an acceptable level of health. And it's kind of sad that we haven't reached that, but it's just interesting to see.
If you guys have heard that joke, all pharma tell this joke on how they actually had a typo at Alma Ata, and they meant to say, health for all by the year 3000. One of those tongue-in-cheek, but not really all that funny in a way, jokes. And maybe we can segue from that comment to asking the question, why not? Why haven't we gotten further than we have by 2000. Any thoughts for what some of the systemic failures have been?
Well, kind of like what point 10 talks about, how we spend a lot more money during military conflict than on healthcare. I feel like, war is something that's been around for ages. It's something that's been part of our, not our personal lifestyle, but like the lifestyle of as the United States of America. There's been the Cold War, Korean War, Vietnam War, both world wars. And a lot of money's been put into that. And through the past century, all that money could have actually been, used, or at least partial of some of that money could have been used for, healthcare rather than military conflict.
Right. So let me around and sort of, have you guys have heard the new rhetoric about the 3 Ds that Obama's administration has been promoting? Does that ring a bell? Diplomacy, development, and defense. It's the 3 kind of pillars of the foreign policy. And in fact, Hillary Clinton, in a recent speech this year, framed the Global Health Initiative as a new kind of diplomacy, almost trying to put it, I think, in the same ballpark as the way we think about defense, the way we think about military spending. There's no right answers to this question, but what do you all think about that as a strategy for helping us rebalance our spending priorities as a nation?
Well, I guess I could say I feel like that's a good start, but I don't know, I just see with that having the same results as this Alma Ata, sort of just having these declarations and these changes in, I guess, like wording or stuff like that, or classification, but nothing really happens with that.
Yeah. How does real change occur? That we've had in the past century in the U.S., where there have been major upheavals and redefinitions of the status quo. What about the civil rights movement and centuries of systematized and really entrenched discrimination and racism? How did that occur? What can we learn from the experience of Dr. King at the age of 25, leading really an army of 18, 19-year-olds and holding a nation to task around an issue that was fundamentally grounded in social justice and a sense of what was right and fair and just. Do you guys study that topic? Please go ahead.
I was just going to say that we could learn from the civil rights movement in the fundamental way in which it was performed, in that, or what it showed people in the United States and the world. It was a movement of relatively young people to stand up and finally say, the way that we're doing blank civil rights is wrong. And so I think that the idea of GlobeMed, or the idea of the Alma Ata, is a way of saying, well, we're not viewing health the way that we should globally or locally, and we need to change it. So it's that we can learn from the civil rights in that it was a revolution of changing a tradition of doing something one way into doing something another way, pretty radically.
One way I've heard it put by a mentor and really a role model of mine, Marshall Gans, who left Harvard University in his junior year of college to go down to Selma, Alabama and march with Dr. King. And when many of the battles had been won in the civil rights movement, he went to Bakersfield, California, which was his hometown, to work with Cesar Chavez around the United Farm Workers movement, and then 25 years later came back to Harvard to finish his undergrad degree and teach at the Kennedy School of Government. And what he talks about was this really interesting nexus of criticality and hope. See, criticality is this understanding of the dissonance between the world as it is and the world as it should be. He says that young people, or so young adults, are at that stage where that consciousness of that criticality is really coming into view. But even as that grows, they're still young enough to have the other key component of real change, which is hope. There's belief that that status quo can be upended, that it can be challenged, that the way things have always been done, and for all the deeply entrenched reasons that they have been done that way, it doesn't have to be that way forever. It's that sort of tinder of criticality and hope that really is our generation's blessing. That's what Marshall Gans points to as one of the key factors that allowed the civil rights movement to be so successful. He contends that most of these key social movements that have challenged the established order have been driven by folks between 18 and 30 throughout history. So GlobeMed is in good company, and I think there are key lessons that we can learn and pick up from the civil rights movement. Are there other reflections from you all on this particular topic? Just before we turn away from the Alma Ata article, a couple other points that I think were made in those 10 points that I'll bring out. One, at the end of point 8, it underlines the fact that these are policies and plans at the governmental level that make primary health care really the focus of a comprehensive healthcare system in coordination with other sectors, as we discussed earlier, and that requires a lot of political will, both to mobilize domestic and external resources. This is a bit of I think more of a dense point, but one that's really, really important to understand and unpack, because if it's necessary that governments are the key actors, then we must partner with the public sector. And if it's the case that they need to build consensus with and buy-in with other sectors, then we need to empower the capacity of that health sector to do that. And if it's about political will, mobilizing domestic and external resources, then this is ultimately a long-range endeavor. This is a sort of internal job where we need to strengthen the hand of the actors who have the mandate to govern, have the legitimacy of that mandate, and have the deep knowledge of their own context and peoples to do that. And so one of the systemic failures, I think, in our lack of progress has been partly the degree of difficulty of this task. A lot of the funding streams, as you guys may be aware, have their own agendas and their own timeframes. They might want results to be demonstrated in 3 months or 1 year or at most 2 or 3 years. And it takes a long time to build relationships. It takes a long time to build the health sector, to bring buildings up from the ground, to empower and train and retrain and ensure the retention of qualified and supported health workers. It's sort of like the sort of 4-year political cycle that we have in the US. It's very, very difficult to do something like healthcare that's going to make you lose badly in the midterm elections and maybe lose your re-election bid for presidency, even though 15 years from now, it will be, we'll have realized tremendous gains to the country and to the national well-being. So very difficult things to do without a lot of courage. And there's not a lot of folks like Partisan Health or Paul Farmer or others who've been willing to do that difficult work, which is 10 to 20 years of long-term engagement, trust building, partnerships, listening, adapting priorities to local needs, and building core capacity for sustainability. Just didn't want us to move past that point. With that being said, I know I'm preaching to the choir.
Just to go off of that, actually, when I was reading that, the part about comprehensive national health system sort of jumped out at me, and it just reminded me of Pat's presentation at PopTech we watched it a few weeks ago. He was talking about how the Liberian president wants you guys to sort of scale up your program, TH, sort of to reach across the country. So I was sort of like, maybe we can tie this a little more back to TH directly. Like, do you have any comments on like sort of how that will be implemented, or I guess where you see it going within the next few years?
Yeah, absolutely. I think we're completely on the same page. Let's get the segue as well to TH and give you guys some updates. And the most important update is this incredible invitation and opportunity from the national government for us to scale up the initial efforts in HIV. And just for the new folks in the room, to give you some context, this was an idea that was really born in 2007, only 3 to 4 short years ago, when Raj, as a medical student, went to the most underserved district of his home country to see what could be done, and found that there was testing but no treatment for HIV, and folks were being given the death sentence without reprieve, even though the life-saving medicines were in country in a warehouse in Monrovia. And just that point of beginning is important to emphasize, because it bodes well for the history that follows. With a group of really disempowered people, HIV-positive women who were from minority groups and had several strikes against them in popularity, and other refugees and war survivors, they lobbied the government, and they were given that sort of audience and opening because Raj had been working with the Ministry of Health before that around drafting its national health policy. But even having access doesn't guarantee a response. So it's to the great credit of the Ministry of Health at that time, who recognized that this was a needed intervention in the country, and took a leap of faith with Raj and with the backing of Paul Farmer and KH and others, that we could successfully deliver those drugs to that population, even though the hospital was a long way from being rebuilt. The clinics in that district were largely destroyed and not yet been staffed. There weren't roads in this area, so we would need to walk the drugs out to people down dirt roads and through the jungle. They said yes, and it began out of a suitcase with Raj and Misha bringing all the money from their wedding over, asking all the guests to just give them cash and donating 100% of that money to pay the initial group of community health workers. And the current program manager, Leafus Kwaito, who now manages a staff of 80 and a budget of $600,000 a year, he didn't know how to turn on a computer when this all began. He was working as a volunteer nursing assistant in the hospital there, while peddling kerosene across the border to the Ivory Coast to make enough money to support his son, who he's raising as a single father. So those are the beginnings, the sort of the core root of TH, which I think speaks to the response that we had to give when 3.5 years later the government turned to us and said, the Global Fund in Geneva is telling us that if we want to be considered a viable partner, if we want to be a player in Global Fund's eyes, we need to scale our HIV treatment program nationwide, and we need to achieve a level of retention in care, or sort of the alive and in care rate of over 70 to 80% at 1 year. And their current rates are down in the 50 to 60% range, while our rates in Zwedru at that point had been about 85%. So they turned to us and said, there's no one else who we trust. There's no one else we think can help us make that goal. Will you scale the program to 19 sites around the whole country? And that's not really a rational decision to make. If you're a small organization like ours, who hadn't scaled the second site, go from 1 to 19, it's kind of insane. But since our mission was really to do everything we could to strengthen the hand of the Liberian government and the public sector to treat the most vulnerable, to do whatever it takes, then the only answer was yes. So we said yes, and then we turned to others for help. I reached out to a colleague and a good friend of mine who was in Liberia at the time, and enlisted his help. And he's been tremendously, has had a huge impact helping coordinate our team, helping interface with the National AIDS program. We reached out to colleagues in Boston to quickly ramp up our back-end support so we could build the database and provide the technical assistance and optimize the clinical systems, be on call for our implementing team on the ground. And we reached out to our communities of concern to look for resource support and other connections to help us do the work, because the funds that were being provided by the Global Fund and the government were really very inadequate for this level of scale-up. And so about 5.5 months in, we have gone from one site to successfully training about 70 accompaniers across 19 sites around the country in 4 successful regional trainings. We have grown our staff, and we've done initial site visits and are pleasantly surprised to find that in a number of cases, actually the majority of cases, the initial training looks like it's sticking, and patients are being seen in their homes by accompaniers who are actually themselves people with HIV in these disparate communities around the country. Just to personalize it a bit, one of our key trainer, a man named Ben Grant, who was just an amazing teacher person, told me this story. Now, Ben is a physician assistant. His father was actually a famous physician. He was a hospital named after him, Grant Hospital. But Ben has remained a public servant all his life. And when Raj and Misha were first coming into the country, they would stay at Ben's home. And when we were ready to grow this year, he joined us as a clinical supervisor on our staff. And as he was relating this first training they did, he turned to me in amazement and shared with me that he was shocked at how some basic information that we all take for granted wasn't known by some of the people who were HIV positive and had been coming in to actually be trained to be community health workers to serve other HIV positive patients. For example, when he put up the slide that showed HIV patients coming in wasted and on the edge of death with severe infections, and then regaining their weight and getting cured of their infections and going back to work, that was actually news for some of these patients. They actually didn't even realize that it was possible to fully recover one's health and vigor, provided that one's remained adherent every day to the medicines. Similarly, it wasn't known that when we can prevent the transmission of HIV from mother to child with nearly 100% guarantee of prevention with the right medicine, so that a HIV-positive woman can have a child, can have a family, or that a discordant couple where one spouse has the disease and the other doesn't, doesn't mean that the disease had to be transferred, that it could be prevented. Some of these key pieces of information about just the medical efficacy of these treatments was received as a message of incredible hope by these patients. And Ben is also a spiritual man, not a pastor, but speaks with that kind of moral force. And he actually used that moment spontaneously to almost deliver a kind of gospel message, to charge these community health workers to go back to their communities and to spread this message of hope, of good news, and make sure that all across the country, because now we actually had an entry point into all the communities around the country, that the basic facts of HIV and the hope that comes with adhering to treatment could be widely known. So we haven't yet seen the effects of that, but we're very, very hopeful. I mean, not only, even though this is a pilot initiative and we're only training 5 companies to see 25 patients at each of these sites around the country, it's quite possible that this effort, led by local Liberians with the kind of wisdom and courage that Ben has, could really push a kind of grassroots movement and renewal in engagement with healthcare and sort of a good partnership with patients we seek to serve. So it's a very exciting time for us this year. Also a very vulnerable time. You know, I mentioned to you that our annual budget this year is $600,000. Last year it was $60,000. This year we have almost 200 people working with THP visa companies around the country. Last year we had about 40. So if you look at that rate of growth, you can imagine this is a tremendously difficult year for us to adjust. We haven't had the management capacity to do that. We're working on it. We haven't been able to provide the level of support that we need and should and want to our local teams, but we're getting up to speed there. And the reason why I think that matters so much is because partisan health 20 years ago was in a similar situation where they knew what they believed in. They had a community that they were deeply committed to. They had great ideas. They had early successes, but they needed solidarity, the global solidarity of folks like Tom White as individual angels and thousands of other folks as a broader community concern who enabled them to sort of made the connections, lend the wisdom, and raise the money to allow them to create a partnership all the way from places like Boston to places like Hajj and Haiti. And so, as I speak to you guys tonight, it is just inspiring to me that all of you, none of you who've yet been to Edru, so that will change soon, would have the courage and the sort of vision to make that shift, to stand with us in solidarity, to support our community health workers and our economic empowerment efforts, and really bring hope to people inside of the world. You know, when we are talking together on Skype calls or face-to-face and reflecting on where we've come, where we're going, and our challenges, it's actually quite often that we turn to groups like yours who have chosen to believe in our work as a source of hope, as a source of strength. And it was in one of these moments a few months ago that one of our women leaders, Rebecca Amara, offered a really powerful metaphor, which I'll share with you tonight. she said, what makes TA strong is, or when we're strong, it's because we are one trunk and many branches. And she meant that the one trunk is our solidarity. It just brings us together, our shared values, our common purpose. And the many branches is our rich diversity. It's all the ways that we are different, that we see things differently, that we bring different wisdom and values to the table. And when we can do both together, when it's a single tree, and we both honor our solidarity and our diversity, then truly we are able to deliver on our core mission. And so we ask ourselves the question all the time: how do we be one trunk and many branches with each other, with our partners, with all of you? Just want to pass that along. Thank you all for believing in this, and for being committed to this, and for the global solidarity that I feel in the room tonight.
Well, thank you.
Thank you.